I am presenting on prolonged variable decelerations in labor. So, as we know, fetal heart rate monitoring is essential in labor to assess how baby is tolerating the stress. Variable decelerations are sudden drops in the fetal heart rate, and they're usually due to transient umbilical cord compression. It's often benign and will improve with maternal position changes, but there is concern when the decelerations are prolonged or persistent and they don't respond to standard intervention. It leads to a risk of fetal hypoxemia and compromised oxygen delivery. It's one of the most common fetal heart rate abnormalities. It's characterized by abrupt decrease in the fetal heart rate with rapid onset, return to baseline. It looks like a V, U, or W shape. And the primary cause again is that umbilical cord being compressed, which that can be transient or persistent depending on the fetal and cord position. Nuchal cords occur in 20 to 30% of term pregnancies. They're usually not clinically significant. There are red flags when we notice prolonged, repetitive, or unresponsive decelerations, which indicate reduced fetal oxygen and potential fetal compromise. So, as midwives, we're looking for patterns in the fetal heart rate and recognizing early when we need to transfer to the hospital. So prolonged variable decelerations usually happen when that umbilical cord is getting squeezed. The cord compression temporarily reduces oxygen-rich blood going from the placenta to the baby. Baby's body notices this drop in the oxygen and responds protectively. So the baroreceptors are pressure sensors and the chemoreceptors are oxygen sensors in the baby's body, which detect the changes. They send a signal through the vagus nerve, which is part of the nervous system, and that tells the baby's heart rate to slow down. The slowing of the heart rate is a deceleration, and that helps preserve oxygen for vital organs like the brain and heart. The cord could get squeezed if it's a nuchal cord wrapped around baby's neck, body. Um, if baby rapidly descends down the birth canal, if the person is having strong, close together contractions, or if there is low amniotic fluid, so there's less cushioning around the cord. Here's where those baroreceptors and chemoreceptors are in the vagus nerve. In my case, it was a G2P1, 40-year-old AMA who had repeat variable decelerations and a few late once we were at the hospital, but all after SROM, immediately after. The fetal heart rate dropped to 80 BPM for 3 minutes. There was a slow recovery to 110, 100, 110 between contractions, but decelerations persisted despite doing position changes. Um, we contacted EMS. We listened with the Doppler from the moment SROM happened to the moment we came into the hospital. Thankfully, she progressed quickly, was able to have a vaginal delivery, and baby was born with a nuchal cord. APGARs were 6 and 8. So even with return to baseline, prolonged or repetitive decelerations indicate significant fetal risk. Um, Oxygen delivery to the fetus briefly decreases, so baby isn't getting quite enough oxygen for a short time. This can happen if the umbilical cord is briefly compressed, like during a contraction. The baby has a built-in protective reflex that kicks in when oxygen drops. This reflex causes the fetal heart rate to slow down temporarily because slowing the heart rate redirects blood flow to the vital organs. When the drop in oxygen is brief, the body or the baby quickly recovers after the contraction ends, and that's a normal adaptive response. But if these drops happen too often or they last too often, the baby can't fully recover between them, and so over time, this can cause sustained low oxygen hypoxemia and acid buildup, acidosis in the baby's blood. This situation can stress the baby and make it harder for them to transition well after birth. And if changing the birthing person's position doesn't make the deceleration improve, it means that the baby's compensatory mechanism, so the way it tries to protect itself, is getting overwhelmed. And at that point, midwives should escalate to hospital care. Other potential causes, cord prolapse, placental abruption, maternal hypotension, even uterine hyperstimulation. So we want to be considering the duration, depth, and frequency of the deceleration, what the baseline variability is, and what the baby's response is to things like changing position. It was, again, normal until We had those repeated prolonged variable decelerations. We changed position. We confirmed fetal heart tones by checking maternal pulse as well. And we also assessed cervical dilation. At that point, she was only a 5. I also just wanted to mention late decelerations. These are when the baby's heart rate gradually slows after a contraction starts and doesn't return to normal until after the contraction is over. And late means it's happening after the peak of the contraction, not during it. And if this happens more than half of the contractions over 20 minutes, it suggests that the placenta isn't delivering enough oxygen to the baby. Again, risk of fetal hypoxia, baby's oxygen levels stay too low, baby's blood becomes too acidic, and long-term effects like brain injury or cerebral palsy. It was category 2 once we got to the hospital. And here are my references.